Okay, ma'am. Yes, ma'am. Next page. Ma'am, the first page. We can start.
Last 10 seconds, you can take your time to organize your thought process. Start.
Hello, I'm Mariam, one of the candidates for the structured discussion today. I have read the instructions and I'm ready.
Okay. So, what is your immediate action, Dr. Mariam?
Okay. So my patient Gravida 2 Para 1 was at 5 centimeters with pathological CTG, and the consultant decision was taken to take her for cesarean. But intra of there was an emergency where there was a low segment, and according to that, immediate action would be to inform the anesthesia operations monitor team and also call consultant and inform the consultant immediately about this. Involve the radiologist and the vascular surgeon. Also, arrange for 4 to 6 units of blood and call the blood bank and ask them to activate the massive hemorrhage protocol and secure another IV line, which is wide bore for the patient. Simultaneously, explain the patient about the ongoing complication that has occurred and what will happen next, as she is under regional anesthesia, and we have to ask for blood to be available, which is O negative blood, if there is no blood already arranged for her.
Okay. Now, since you have decided on all these things, how you will approach the rest of the surgery?
Okay, so once the consultant arrives, the senior consultant should be starting the surgery. The main thing is now to deliver since it's an emergency, delivery of the baby is necessary. So, as there is a vascular segment at the lower uterine segment, but the sonography says that the placenta is anterior and up high, we can try for a lower segment incision, or a vertical upper segment incision can also be taken into consideration with discussion with the consultant. Then the next, after delivery of the baby, green armitage should be used to secure the angles, and all the other bleeding points needs to be secured via the artery. Immediate management of bleeding needs to be taken care of, and uh, after delivering the placenta, the bleeding needs to be secured. If the bleeding is not under control, we can think of stepwise device. Other arteries, such as uterine artery, can be ligated. And your ovarian artery can be ligated. Stepwise manner devascularization can be done, but this all has to be immediate, because if at all the bleeding is not under control, a hysterectomy decision needs to be made, and this cannot be delayed. uh, then after that, if there was a lot of bleeding, we have to replace the blood loss quickly and effectively. If needed, we can do a CBC at the full blood count at that particular moment, and we'll have to leave an indwelling catheter for monitoring the input and output of the urine. And after that, we'll have to transfer the patient to intensive care unit, as she will require monitoring.
Okay. So what will be your post-operative management for this case?
Okay, so for post-operative management, the patient needs to be shifted to the intensive care unit. She needs to be monitored via the MEOWS chat, which is the modified obstetric early warning score. The patient needs to be given antibiotics for the next 5 days. Because of her raised BMI and emergency section, she needs to be given thromboprophylaxis according to her weight, and at least for another 10 days. She needs early mobilization and compression stockings needs to be provided. Input output monitoring of the patient has to be done, and an incident form needs to be filled for the same. And then the patient and the family needs to be debriefed about it. In on the discharge card also, it needs to be mentioned about the findings and the complications that occurred. And patient needs to be informed about the red flag signs post operatively, that is severe abdominal pain, vomiting, and we have to mention the emergency contacts that she needs to have. Also, we will inform to her community midwife and GP. We'll write back to them.
Okay. What are the clinical governance issue you will deal with this patient? You mentioned few of them, but still, if you want to add.
Mhm. Since it's an intraoperative emergency that took place initially, we'll have to debrief the patient, the family members, and the relatives after the operative procedure. We'll have to complete the incident form. We'll have to do the duty of condor, that is, communicate with the patient about the outcome of the risk management report that will take place. We'll also have to do a risk management team to inform the risk management team to do a root cause analysis, and we'll also have to communicate and debrief to the GP and the community midwife about it.
Okay. Anything else you wanted to add to any of this task? You are having time because.
Okay. Uh, the multidisciplinary team, which is the vascular surgeon and the radiologist, will be needed if at all the bleeding is not controlled and we need uterine artery embolization. That can be used as one of the methods. Also, the vascular surgeon will be a better a person to help us in this entire situation, and the decision for the hysterectomy needs to be done by two consultants. Um, yes, ma'am.
Okay.
That's
Okay. Shall I stop it now?
yes, ma'am. I don't remember anything more to say.
Okay, so it's completed within 6 minute something 33 minutes, okay? 33 seconds. So you are having plenty of time. You managed very well. Anybody would like to give a feedback for her? Anybody would like to come up? No one. Okay. So you have started on a very positive note. You have started introducing the yourself and then started with some emphasis or some as in as bar tool. You started emphasizing on the topic what exactly you are dealing, and then you had approached the task. Okay. First question, second question, third question, and fourth question. There are few missed points which are there, but overall it was a good task. In the first, so simultaneously I will be sharing my answer key what you missed in the
Okay,
first
ma'am.
task. Okay.
Okay,
So
ma'am.
that okay. So what will be your immediate actions? So the immediate action will be stop the procedure. Do not further if which are normal. Uh, See, we have seen actually. So we need to inform first. Okay. So we will not go further. We will not continue the surgery. Hmm?
Okay.
the first thing, you will not be overzealous, or you will not continue the surgery. You will, once you have seen that vascular segment, you will withhold the procedure for that time being, if FHR are normal. Okay, as of now, if the FHR are normal, we know that this is a pathological CTG. You have to deliver the baby as early as possible. Activate your CRMA protocol. That means you have to communicate with the colleague. So you have communicated very well with your anesthetist colleague, and you called up your senior consultant also. Okay.
Yes,
Similarly, you
ma'am.
have to inform the anesthetist for what? Because you are anticipating the bleeding, so he needs to put two wide bore. Okay, two wide bore IV line. Okay, and
Ma'am.
then for what? The second thing will be arrange blood and blood cross match extra. Hmm? And blood products. So this is your first line which you have completed. Scrub team. You may require extra instruments, extra suture material. So you have to inform the team. And then the last person will be inform the consultant. Then ABC approach, basically anticipating that the bleeding will be there. So what you are taking precautions. So here not resuscitation, basically you are just taking precautions, anticipating the bleeding amount. Okay. Inform your blood bank. So you have informed the blood bank. Assess baby's condition pre-induction. Since it was a pathological NST, we need to deliver baby as early as possible. So stabilization of mother by taking a control of the situation will be immediate situation. Here we need to see whether what exactly we need to continue. What exactly we need to be in a controlled calm mind. Then decide whether to go ahead further, what will be your approach to proceed further, and explain this to the patient since the patient is under epidural analgesia. If there is torrential bleeding while taking an incision, you can ask for uncrossed matched blood group, O negative, KL negative blood group in the theater. If there will be any blood
Still
means
bleeding.
anticipated severe blood loss, because it is actually here we are not here. The first thing will be, what will be your approach? You are seeing something which is not normal, and you are anticipating a bleeding. Hmm? So you are taking
Okay.
measures to minimize all those things. Okay, so this is my first question. The next question will be, how will be your approach to the rest of the surgery? So the approach, see, the situation is emergency situation, because we need to proceed with the delivery of the baby since the pathological CTG. So most likely we can go ahead, means we'll try to avoid the lower vascular segment. If possible, upper uterine incision can be taken, but if the consultants are there and people are there to manage the vascular segment also, then we can go through the lower uterine segment or upper vertical incision. It will be decided by the consultant. Either the consultant will be performing, or mostly it will be the consultant, senior consultant will be performing, or you will be performing under his supervision. He will be there. So the approach will be, identify a vascular plane. If possible, then only LUS. Otherwise, vertical upper segment incision will also be suffice. Before taking incision over large vessel, one can also consider ligating those vessels, okay, or in applying small artery forceps or small vascular clamp over the vascular
Okay.
pedicle. Okay, vascular pedicle. Then deliver the baby. So these are the minute steps which you have to ensure. Means this is what exactly how you are going to apply in your clinic. They wanted to see how you are going to do it. Okay, so next, deliver the baby. Okay, deliver the baby. Apply green armitage, apply any artery forceps as early as possible to all the vascular channels, and secure those hemostatic measures. Okay, you mentioned about securing those hemostatic measures. You have not mentioned anything about the baby. Baby is pathological CTG, so you have to hand over this baby to the neonatologist, assess the cord blood, deliver the placenta with the consultant, and secure bleeding vessels. Okay, secure bleeding vessels hereupon, because this is a, although it's a vascular bleeding, but here you can take a help of injectable tranexamic acid or not. Yes or not? If there is no contraindication, even that active management of third stage of labor needs to be offered here. Hmm? Any, yeah. So active management of third stage of labor is important here, and tranexamic acid, because it is the first medical line of management along with stepwise devascularization. Okay, so you mentioned stepwise devascularization, that medical line of management, you missed out on that. So stepwise devascularization is unilateral or bilateral uterine artery, ovarian artery, and stepwise into internal iliac ligation if the expertise are available, or here you can take a help of intervention radiologist for umbilical artery embolization.
Okay.
Sorry, not umbilical, uterine artery embolization. Yes.
Yes,
So
ma'am.
we are going stepwise here. We are going stepwise. Before that, it is medical line of management is must. If unsuccessful, then yes, with the help of two consultant, we need to proceed with the hysterectomy. If patient is hemodynamically unstable, in the best interest. Okay, so all those words will automatically come here. In the best interest of the patient, if patient is hemodynamically unstable.
Okay, ma'am.
Hmm?
Yes, ma'am.
So hemodynamically unstable, and it is not
Best
possible
interest.
to, yeah, leave the drain. Since you had done such a difficult surgery, always ensure that you will put a drain for peritoneal cavity. And here actually, when you are anticipating and the bleeding is ongoing, depending upon the amount of blood loss, we may activate massive hemorrhage protocol here. Replace blood as quickly as possible effectively, along with blood and blood products. So means how much will be your ffp, how much will be your cryo. Okay, and this will be missed, so that your aim of hemoglobin, aim of platelet, and aim of what it is cry means fibrinogen is needs to be maintained. It needs to be maintained.
Replace.
Yeah, yeah, so it should be replaced, because if it's a massive blood loss, then we have to activate your blood and blood products transfusion as early as possible. Then the rest of the things were normal. That leave indwelling catheter for in situ. Whenever such kind of bleeding is there, there is always a unsafe act. We use most of the swabs. Most of the swabs has been used. So always ensure that your swab instrument count will be confirmed, and you will complete your WHO safety checklist before completing the procedure. Label uterus if it has been hysterectomy. Label your uterus and send it for histopathological examination. This is just a routine thing. Okay. Close abdomen systematically along with drain. If hemodynamically unstable, consider CVP, transfer to HDU, ITU. If the blood loss more than 1.5 liter of blood, then SOS blood products transfusion, check blood. Now, most of the time, what is her blood group? We do not have any idea. So always mention if it is a blood group is anti-D negative, then RH negative, then anti-D will be given according to the
Okay.
KB test. Okay. Once the patient will be shifted, you will would like to check her full blood count coagulation screen. So this is my complete answer of the part second question. The third question, yes, we had to shift this patient to the HDU on MEOS charting. We need to offer monitor her continuously for next 24 hours. Antibiotics for 5 days, preferably injectable, followed by oral. Thromboprophylaxis, input output charting, incident reporting, risk management issues, debriefment. Now, if it is a hysterectomy, patient will be in a traumatic situation, offer counseling support. If not hysterectomy, counsel about the implication of this procedure on her subsequent pregnancies. Okay, because high risk of recurrence. Okay. Here you can again advise her regarding breastfeeding, because the patient is breastfeeding and baby's condition. You can assess here, and you can add that point also, since the patient is post delivery.
Yes, ma'am.
Now, coming to the clinical governance issues, you will be dealing with post-operative informed risk management. This even discharge. Okay, so you had mentioned very nice point here. Discharge to primary care and GP
Red flags.
GP man follow up very nicely. Okay, so
GP and
all those,
community
yeah.
midwife. Ma'am.
Yeah, so midwife, yeah, community midwife, follow up 24-hour contact details. So these are the all points which you can mention here. Depending upon the hysterectomy, offer counseling and support. If not, then discuss contraception if the hysterectomy has not been performed, and high risk of recurrence in future pregnancy. So that also needs to be discussed. Clinical governance issue, you had mentioned all the clinical governance issue. Basically, inform risk management team to initiate root cause analysis, debrief patient and family, identify areas where we need to request, we need to see whether we can work on it. So MDT meeting, training, then communicate with the patient and family, offer them duty of candor, offer further debrief with the consultant. Okay, so all these things, and you can discuss this case in your team meet also. So those are the important points. So domain wise scoring, communication with patient and families, introducing self and role when you are performing the procedure, discussing debriefing, consent, risk management issue, further follow up with the GP, follow up with 24-hour contact details. So this is included in communication with patient and family domain. Colleague, basically how you are going to communicate whether it's an emergency situation. So this is an emergency situation, somewhere somehow you have to say this is an emergency situation. Okay, anesthetist, nurse, scrub nurse, midwife, call for help, consultant, blood bank, vascular surgeon, you have to mention all those points. Activate massive BT protocols, neonatologist, HDU physician, post surgery, liaise with risk management team, referral to primary care, that is community midwife and GP, usually about 5 weeks after. No. Okay, so this is your communication with colleague domain. Patient safety, activate massive hemorrhage protocol, which you had mentioned. Ensure adequate blood and blood products will be ready. You mentioned emergency O negative, K negative blood will be available. 2 wide bore cannula, ABC protocol. This is actually a buzzword. Many a times these are the buzzwords. Okay, so this emergency, assessing that it as an emergency. Okay. So these are the buzzword. So you have to take this. First, it will be always medical line of management, and then it will be going systematically surgically, and the last will be hysterectomy. Okay, with the help of the two consultant in the best interest. HDU monitoring, DVT prophylaxis, risk management issues, monitor and know what to do if severely affected. Simple case of vascular lower uterine segment, how you have presented. So the knowledge is good, only few points here and there. Overall, it was a good station, dear.
Okay. Thank you. Ma'am, if we have to explain this in SBAR format, can you give one example for this? Because
Yeah,
like,
so
explain this in SBAR,
let's
like what would be the assessment then?
okay, so let's see what it is actually. So situation here is an emergency situation. So I will say I am undertaking a emergency cesarean section for a pathological CTG in a second gravida, 39 weeks pregnancy at 5 centimeter with previous USG suggestive of upper segment placenta. Hmm? So anticipation is a lower means lower vascular segment which may bleed torrentially during the procedure. Okay. So this is what actually, or there might be a massive PPH or a major PPH if we go ahead with the surgical modality. Hmm? So the first thing is what we are doing, or the situation here is basically lower uterine segment, which is vascular in a background of cesarean section for pathological CTG in gravida 2, para 1, leaving 1, 39 weeks gestation. Okay. That will be also an option. Anybody's having any question?
Madam, this would not have been identified in the antenatal period whether the placenta was low lying or not.
It was actually not, they had not mentioned it is placenta previa. They had just mentioned that the vascular blood vessels were there. So we can, that can be seen in the, that can be informed in the risk management team. Okay. So if it is a low lying placenta, then why it has been, whether it was a low lying or only vascular lower segment. So that can be part of that risk management issue. Whether we had missed low lying placenta.
Okay, madam. Actually, only for a vascular lower segment, if otherwise the placenta was upper anterior, this much usually, I mean, in practical purposes, we do not follow so much. So
True,
that's what I was
absolutely
trying.
true. Yeah, absolutely true. So that's the reason hysterectomy should not be coming. So the first thing will be always medical line of management, then that surgical ligation. So ligation of the active bleed or active sinuses is important. And then
Yes.
stepwise devascularization. And if at all in spite of all these things, if your
Mm.
lower segment is not stopping bleeding and it is affecting patient hemodynamically, then only with the help of true consultant, hysterectomy will be an option in the best interest of the patient. So
Okay,
those
madam.
sentences should come into your mind. Okay. Don't jump directly on hysterectomy.
Correct, correct.
Okay. Okay. So, Anusha, you would like to take the next task?